All right, good morning, everyone. Welcome to another meeting of the Informed Prostate Cancer Support Group. I want to give a special thank you to the Sanford Burnham Prebys Medical Discovery Institute for once again allowing us to use this auditorium. Perhaps the next time you see it, it will have changed a little bit. They're going to do some renovations, repainting, new seating. Should be quite nice. I'd like to introduce the principals of our organization today. We have Bill Lewis, who just walked in, our president, and does the wonderful newsletter summaries. Jean Van Vliet, our director and treasurer. Steve Pendergast, our secretary and newsletter editor. Bill Manning, director and videographer. Myself, Aaron Lamb, director and facilitator. John Tassi, our webmaster, and Bill Bailey, our librarian. And of course, there's you, well over 900 volunteer members, and every one of you could be a volunteer too. Are there any people here for the first time today? All right, excellent, quite a few. Hopefully each of you were given a newcomer packet as you walked in. This gentleman here, I think you were already in the auditorium. Did you get a newcomer packet? All right, before you go, please make sure that you get one of those. It will have a cover sheet on it. Please fill out the cover sheet and get it back to either me, Bill, or Jean before you leave. That will that'll trigger a phone call to you sometime in the next week from Bill or Jean to help discuss your situation and see how we might get you the information that you need and help you answer your questions. So, yeah. All right, so that's the whole packet. It contains an information kit as well, leading you to articles and booklets. And as I said, there'll be a welcome call. Now, we saw, I think, about 4 people here for the first time. How many people were recently diagnosed? Go ahead and raise your hand. All right, excellent. Some rather newbies here. Who have had PCA for less than 1 year? All right. How about 1 to 4 years? All right, 5 to 10 years? 11 to 15 years? Quite a few. And beyond? 21. 21. Anyone longer than 21? Oh. 16 on Larry. Yeah, the key thing to realize for you newcomers is that this is a treatable disease that you have a long life left ahead of you, and you have a huge amount of experience among the men around you on the various treatments and even how they've progressed over the years. So do take advantage of that. The next slide will do a survey of what types of treatments everybody has had. And so if you yourself are thinking about a particular new treatment and curious about perhaps what the best doctor is, what other people's experience are with it, take a look around and go up to one of those people that raises their hand and ask them about their experience with it. And so who's on active surveillance or has been on active surveillance in the past? All right, excellent. And how many have had surgery? Okay, quite a few. Radiation, whether it was proton, X-ray, brachy, ADT, and hormone therapy. Yeah, quite a few too. Chemotherapy. All right, a couple here. And new treatments, whether it's focal or immunotherapies, Afigo, Pluvicto. Yeah, these are becoming a little bit more popular, and we've got experience in our audience here. And how many people have had recurrence of their prostate cancer? Yeah, another big reason why we are here. And who is undecided on their future treatment? That's right. A lot of people here looking to answer some questions. We are on Instagram. We are approaching 800 followers. I'd love to see us break 1,000 followers. I don't know if that enables us to any other tiers of service and advertising within Instagram, but please do look us up, follow us, click on some of the posts and like them. And we are on YouTube as well. As you know, we record all of these meetings and post them to YouTube for us to review, as well as others that might not even be in San Diego are able to access such a wealth of information. A few people have mentioned that the words kind of go by a little bit fast, but once you log into Instagram, you can actually review the video and pause it when you need to. Now, our support to you comes in the way of our website. Hopefully, you have all seen that. On that, you can get all of the links to see the new upcoming meetings. You can see all of the old newspaper, all the past newsletters that have gone out. Links to anything from YouTube to articles that can be of use, and especially the PayPal link that you can provide a donation to us. We do also send out a newsletter by way of the website, and you should be getting emails with those attached as well, and I believe we can still send them by mail if you need a physical copy. And there's also some copies out in the library this morning. We meet monthly on the third Saturdays of every month. We don't meet in December. And as I'll reiterate later, we've had a slight schedule change for next month. In April, we're going to meet on the fourth Saturday of the month, not the third. We'll be meeting on the 27th here next time. And on the website, as well as here, you can get a hold of Jean and Bill on the hotline numbers that you see. I know that, especially for the people recently diagnosed, you might feel overwhelmed and feel the need to urgently get some questions answered, whether you have an upcoming procedure that you're questioning whether or not it's something that you should be doing, or should be doing something more. These hotline numbers are available to you to help you, especially in those situations. Others have support to us as well in the way of a very inexpensive PSA testing by Ulta. You can see the link there as well as on our website. There's also the Promise germline DNA saliva test, which is free and no cost. And there's the YMCA Livestrong prostate cancer therapy exercise program, especially for those on ADT. I recommend looking into any of those if you are interested in what they can provide. We do need volunteers. We need people to suggest and recruit new speakers. And for our member roundtables that we have once or twice a year to share your experience. I know that we had a wonderful roundtable recently, and somebody came up afterwards and said, "Hey, I want to share my story as well. Please do see Bill and let him know that you'd really like to share the experience that you have with the other members." You can contact us through the website or through the hotline number there. Now, I want to reiterate our support group purpose. We share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals, and any sharing by any one of our group may not be a substitute for your medical counsel. And we do need your support. We are a 501c3 nonprofit organization. And if you could pass the baskets around. Your donations are tax deductible. We have no medical or religious affiliations. And the largest costs are our website, advertising, mailings, and so forth. Question here. Yes, you can. In fact, right there it says, please make a donation online via PayPal. There's also a address there where you can send a check if you want to bypass the whole PayPal thing. You can also, give a check to in the basket or to Jean another time. Your donations are greatly appreciated. Think of the value that this meeting and all of the information that we provide online provides you. And I do hope that you're thinking generously when you make your donation. Next month, at our upcoming meeting, we'll have updates on the latest trials, testing, and treatments for prostate cancer from Dr. Lamb. From prostate oncology specialists up in Marina del Rey. This is one of our most popular meetings of the year. We have him come every year, and he provides access to a huge wealth of information that you might not otherwise be able to get. I really recommend that you attend. And once again, please note that for next month only, we're going to meet on the 4th Saturday on April 27th. As for today, we have Dr. Michael Kipper. He's a PET CT imaging technology specialist, a clinical professor of radiology at UCSD. He did his undergraduate and medical school work at UCLA with postdoctoral training in internal medicine, endocrinology, and nuclear medicine. He is one of the foremost authorities on this topic. And so, Dr. Kipper, would you please take it away? Feel free to ask questions as we go along. I can run around with a microphone to, what's that? Yeah, if you can hold your question to the end, please do. But sometimes, something to clarify a slide or something goes a long way. We won't get too deep into questions to slow the presenter down. And the only last thing I'll note is, especially for you newcomers, if you need the restroom, exit out the back of the auditorium and down the hall to the left. All right, so with that, take it away. Sorry, one more time.
Now, could we get it started as a slideshow from the first slide? Oh, that looks like it worked.
Yeah,
so,
yeah.
So is this the advanced?
This one right here.
Right here.
Yep.
Thank you so much. Well, good morning to everybody. It's nice to be back. Always a privilege, always a pleasure. This year when I received the call, I was happy as always to respond as I've been responding more recently to requests, and that was, who is this? And that seems to be happening to me a little more often, but as I enter the very last stages of my career, I've been blessed to have been involved in prostate cancer for many years, including 8 years at the Prostate Cancer Center here in La Mesa. So I've gotten to know some of you. I know some of you from previously. And for those of you who know me, I'm very informal. We will try to hold questions till the end. I won't go home until every question has been ignored. And as far as we go along now, I want you to sit back and relax and just hopefully learn some things. But as I said, I'm pretty informal. I want this to be not only educational, but a little bit entertaining. I'll give you some social anecdotes you can take with you to cocktail parties. And just one thing to mention to you, when we were deciding on the topic to present, because I mostly do imaging and research in the area, Jean thought that would be the topic to cover, but we also talked about another lecture that I give to the residents and the faculty at UCSD, and it's about the journey of a patient with prostate cancer from the date of diagnosis to the far advanced treatments that are now available, and we just kind of take the patient from day one on through. And Jean thought that might also be an interesting topic. So if any of you have any interest in that, just let Bill or Jean know, and I will be happy to come back. Usually we are graded when we're done, and people put their comments down. And the last time I did this talk, there were some nice comments. Someone put down, I forget what they said. I didn't realize he was out. And that was nice because I had to, they apparently thought I was in prison. Someone else wrote, are you kidding, with a question mark. Someone wrote that they gave me a 10, and in parentheses put out of 100. And there was just lots of good comments by that about the group. So if you have any interest in that topic, just let Jean or Bill know. With that in mind, and thank you, Aaron, for the introduction, and thank you for getting me set up. We're going to talk about all that's available to us now in imaging, and the outline will give you a little bit of idea of what we're going to cover. First, an introduction, then a little bit of background. Not going to bore you with a ton of details that we can't use going forward. We'll talk about all the various imaging modalities that are available to us and may become available soon. Because the good news is that in my position at UCSD, we are remaining on the forefront. We will have things in San Diego that no one else has. That has been the case in a number of other things, including Pluvicto, certain imaging modalities, and we pride ourselves in trying to stay not only ahead of the curve, but available to everyone in the community, especially those that are in other institutions. We're always happy to help and tell them what we're doing in particular areas, because a lot of times there are things that those patients can benefit from, and we can see them on a short-term basis, and then obviously they continue with their care at their normal institution. Theranostics has gotten a lot of play in the last year or two. Theranostics is the combination of imaging and treatment with usually the same agent or one that's very close to it. And there's a lot of good science behind that, and I'll share with you some of the benefits of theranostics, and we will have one of the, or do have one of the major theranostic centers in the West. And we'll take a peek into the crystal ball and see what the future might hold, because everybody, this is such a well-educated group that I know that you like to know what we might be doing and what might be coming along in the future. Now, prostate cancer, just to refresh your anatomy, I don't think I have a pointer. Is this a pointer?
No, it's just you can move it around there and you can see both.
Oh. Technology is incredible. Anyway, this is where the prostate gland sits. It's behind and below the bladder. And this little thing up here is the seminal vesicle. And that's very important because at the time of diagnosis, we need to know if the seminal vesicle is involved, because that majorly changes the course of treatment. And as you can see, the rectum sits behind it. The urethra going through the penis here, testicle, and so forth, some of the other normal structures that we see. So you kind of have to know where the prostate is, and it helps you understand, I think, with some of the radiation treatments, why we have to be careful, because there are other organs around there. And if they suffer the neighborhood effect or friendly fire from our treatment, those particular organs, as far as how they're affected, can affect us for the rest of our lives. In the U.S. this year, it's estimated there'll be about 300,000 new cases of prostate cancer, and about 35,000 of us will pass from their prostate cancer. The number of prostate cancer diagnoses per year is going up. Part of that is because we have better diagnostic methods. We can find it easier than we used to be able to, when in the bad old days, we kind of had to wait until it spread somewhere and it was already pretty far advanced. But nowadays, with the PSA and ultrasound and other things, we can find it earlier, so the statistics are skewed toward our better diagnostic methods and earlier diagnostic methods. And let's face it, we got a population that's much better informed. Okay, people know about genetics now. They know their family histories now. They make it a point to find out what's going on in the family. I was relieved to know that there wasn't ovarian cancer in my family, so just one more I got off my list. As had been mentioned, prostate cancer, 56% more common in African Americans. We don't have all the answers as to why that occurs. Obviously, that's being looked into, but at the present time, we have that statistical fact. So we take advantage of those types of facts, even though we might not be able to fully explain them. So what do we start with our patient? And we're not going to spend a lot of time with this, but one of the very first things that happens, of course, is the patient will head off to his friendly urologist for a urologic exam and a digital rectal exam. And there's Mr. Potato Head bringing the key organ with him to his urologist. And that, of course, is his plastic penis that came off of his potato head body. I know a lot of you thought it was a machine gun in there, but no, he wasn't a criminal. He just thought it was important to bring an organ with him. Oops. Now, let's see. There's probably no way for me to go back in time, is there? Unless I was Superman.
There you go.
Thank you. And next thing, of course, is the PSA, still a very, very helpful test. The gentleman that discovered the PSA says he wished he'd never discovered it because it's being used too much and it's being used in too many scenarios. But that in mind, I don't think any of us here would be comfortable if we did not have a PSA to follow our status. Other than the PSA and the digital rectal exam, then kind of we start the evaluation. One of the very first things that's done is an ultrasound, and I just wanted to show you what a typical ultrasound looks like in a patient with prostate cancer. And this over here is the normal right side of the prostate, kind of homogeneous, white, looks like the rest of the tissues around it. But if you have a prostate cancer, it'll show up as a void or a black area in the scan. And when we come across that with the ultrasound probe, it's a fairly high likelihood that that is a prostate cancer. And that'll help the urologist to decide about where to do biopsies. So the ultrasound is something we actually really need to have. And we don't just always use the ultrasound in exclusion. Nowadays, what we're doing, and some of you have probably gone through this, is having the ultrasound combined with the MRI to specifically place a worrisome lesion that can then be biopsied at the time of prostate biopsy. Now, some of the studies we have available, and here's why I'm standing up here today, other than being able to hold on to the podium, is that we have ultrasound with biopsy, we have ultrasound with colored Doppler, we have MRI with ultrasound, as I just mentioned. We have MRI of the pelvis and the prostate. We still have bone scans, and there are two types. There's a normal standard bone scan that most people go through, and then there's one with a different agent, which is orders of magnitude better than a standard bone scan, but not typically covered by insurance. But there are some insurances that will cover it, and I'll show you how nice those bone scans are. We now have something called SPECT and SPECT-CT. We have SPECT-CT at the university. There are not too many people in San Diego that have it. And SPECT-CT means you do a nuclear scan and there's a CT component to it, and you put them together and you can find out what the physiology of the prostate is, and you can find out what the anatomy is at one time. So it really, really improves the accuracy of your test. So if you can be in a place that has SPECT-CT, you and your physician are way ahead of the game. We have standard CT, which is good for looking all over the body. It can look at the bones, it can look at the lymph nodes, it can look at the organs. Where it's no good, interestingly enough, is at the prostate. Okay, CT doesn't find us anything in the prostate gland. So these will be the first few tests that I show you, and then there's a second list, and we will have covered the waterfront as far as what are the available imaging tests and when they might occur in the course of your treatments. We can also do DEXA. For some of the gals that are here, you may have had DEXAs, and the guys with prostate cancer typically need a DEXA study. And a DEXA study is a very simple 10-minute study with minimal radiation that evaluates the strength of your bones. And the reason for that is that the androgen deprivation therapy agents will reduce the strength of your bones and make it much more likely that you're going to have a fracture. So we want to know what the strength of your bones is so that if we need to put you on something to help that, we want to do it. Because the complications of osteoporosis, again, same with gals, same with guys, are bone fractures, typically of the hip, the wrist, or the lower lumbar spine. Is that important? You bet. 20% of patients who suffer a fracture of the hip do not survive more than a year. So that is a very serious complication of low bone density. Okay, so I had talked about some of the modalities. In the upper left, this is a regular ultrasound, and see kind of homogeneous, kind of uniform distribution of the material, versus if we use something called Doppler, which is just a software application to the study. And all those little red areas are the vascularity in the patient's prostate. And typically prostate tumors are quite vascular. And if you see little areas with hypervascularity, you better be concerned that that might be an area of prostate cancer. So the beauty of Doppler, if you can get it, is it can identify areas that might be holding on to prostate cancer. Now, this is an MRI examination, and an MRI is a wonderful advancement, of course, gaining some people the Nobel Prize. Because it delivers no radiation, it's the best thing we have going for soft tissue, and it's especially good in two areas that are of major concern to us: breast cancer in our female patients and prostate cancer in all of us. And what we see, depending on the method we use with the MRI, is, for example, in this patient, you can see I put a circle around this area where there is no activity like there is on the other side. This is the normal right side of the prostate. This is the left side where there's this glaring hole in there. That's a prostate cancer, and the MRI can find it without any difficulty. Now, the other advantage of the MRI is that as long as you're down there, you can look at the lymph nodes around the prostate, you can look at the bones in the field of view, and you can look at things like the seminal vesicle, at the nerves that are down there, at the vessels that are down there. So with one examination, you have a really good evaluation of what we call the prostate bed. And this particular study showed us prostate cancer in the left side of this gentleman's prostate, but thankfully everything else was clear. The other thing prostate will show you, MRI will show you, and this is just a little different way of doing it now, is you can see if the prostate cancer has spread beyond the prostate gland. Now, you can't do this with other things that we have. You need MRI to do this. Ultrasound won't tell us this. CT will not tell us anything about the prostate. And then obviously bone scans and other things we use aren't going to tell us this. But the answer we're going to get from the MRI in this patient is that if this is the prostate here, which it is, it goes beyond the borders of the prostate on the right side, lower right side. So that is what we call extracapsular extension. The capsule around the prostate has been violated, and that is a sign that this is now a high-risk patient. And that's what we want to know about you very often before we even start treatment. Are you low risk? Are you middle risk, intermediate risk, or are you high risk? Because that tells us how we should treat you. And one of the signs of high risk is a tumor that extends beyond the capsule. There are many others which I won't go over now. Dr. Lamb will probably go over some of these next time, and Rich has got a good topic for you to all hear, and it makes my job a little easier today. But some of the other high-risk categories include a very strong family history, a PSA that is 8, 9, or 10, extracapsular extension, involvement of the seminal vesicle on either side, and positive lymph nodes or distant metastases. And those are only some of them. So we want to be able to categorize our patient at the beginning so that we can then make the best decisions at that point to hopefully continue with this patient in what we refer to as the cure bucket, that we can still cure this patient because we have a good feel for where it is and what organs or tissues are involved. Now, some of the modalities that I mentioned too, if you look at the upper left, I think I can convince you that this is a regular bone scan. Back, front, head, feet. And you see a number of these little black spots around, okay? And those are metastases, okay? Those are areas of the bone that are trying to repair themselves from some type of damage or injury. That could be trauma, that could be fracture, that could be arthritis, that could be cancer. So the bone scan is very good at finding things, but it's not very specific. It often cannot tell you exactly what's causing it, whereas the other things we have can tell you that. But now look to the two images to the right, done really within the same time frame, within days now. The first one is a SPECT study, where instead of you just lying under the camera and it just goes over your top and bottom, you can actually have the camera spin around you, and then we can slice you like a loaf of bread and look at each slice and get much more detail than we can with the standard bone scan. So that's called SPECT, and that's very good. But what is even better is the SPECT CT that I mentioned, where you can get the SPECT part of it plus a low-level CT, meaning low radiation dose, goes quickly, takes seconds to do, and you can specifically place the abnormality to the bone and see what that bone looks like. So that dramatically increases our specificity of the test. And the one on the far right, look at all the new lesions you find. Look at where you can actually place them, and we have ways of slicing that to be 100% sure. So the other point of the scan is on the left is a regular bone scan, and on the right is that new agent, not new, but the agent I was talking about. It's called sodium fluoride. And need I tell you that the sodium fluoride found much more disease than the standard bone scan? So we would have horribly understaged the patient if we used the bone scan to the left, which is what most of us get, versus if we had used the sodium fluoride scan to the right. Now, would it have changed his management? Probably yes nowadays, maybe not. But we know from both studies that there was more than one focus within bone. So that helps us decide what we want to do. But some of the newer agents require more advanced disease in the bone than we may have been able to show with the standard bone scan. So we like sodium fluoride. It is our friend. Osteoporosis. Don't need to spend any time. We just measure the bone strength in the lumbar spine, in the hip, and in the wrist. Down here is a CT scan, which I told you is very good outside the prostate. And this is just an example of what you might see with a CT scan, and I'll tell you why I'm even mentioning it in a minute. And that is, you can see these clear areas. They happen to be in the liver. So those are metastases. And then you can see all this stuff in front of the spine here. And that's a huge conglomeration of metastases in the lymph nodes. So with this one CT scan, we can also then say, this gentleman has metastases in his liver and his lymph nodes, and add that to what we find out about the bone scans, and we have a pretty good idea of how that patient should be treated. Now, the MRI, as I said, is for precise localization as well as precise characterization of certain lesions. The question when we're doing the ultrasound with the MRI is because it's so good. Do we need to just do the regular biopsies as well, kind of the blind 12 biopsies that so many of you had? The actual answer is yes, because if you add those blind 12 biopsy, the incidence of finding things goes way up. So we don't just do the ultrasound and MRI and leave it like that. We also just, with the ultrasound probe, do the regular biopsies as well. So anybody by show of hands have had the fusion biopsy? So a few of you had. And as you guys remember, it took a little bit longer to do the study. There's a little more a few more technical issues involved, but we get a lot of additional data. And that's the current way, if the modality is available to you, that you should have your biopsy, is the ultrasound with the MRI. And here's an example of what the image-guided biopsy is. So if you have your ultrasound, it shows us this dark lesion here, kind of similar to the very first one I showed you. And then when you do your MRI, you get this area of increased activity in the right, here in this lobe of the prostate, sex to the left lobe. In this case, the patient's facing the wall, so this would be his left lobe. This is his left lobe. And this, stacked on top of that, tells you that the odds are unbelievably high that this is going to be a prostate cancer. And for those of you who have had biopsies, which I think is probably most of you, the fewer times they need to go into you with that needle, the better. And if they can get their diagnosis, we're happy campers. We're going to leave that one for now. So why does PET help us in looking at studies? This is a good example of why we like MRI. And it's a patient that underwent a PET MRI study where the MRI was fused to the PET. And although this is in the area of the brain, I think it's a better slide to show you so you don't forget it, because it will also be on the test. So I will give you that clue ahead of time. So on your left is patient 1 who had combined MRI and a PET study. And on the left is the MRI, and it looks like there's nice uniform distribution throughout on the MRI. Nothing much to see here. Here's the PET scan, and all that yellow is the very active activity on the PET scan, which shows metabolic activity. And taking it to the next patient, there's the MRI, and here's the PET scan here. And we're going to talk a fair amount about PET scans coming up for use in diagnosing and then help in treatment of prostate cancer. So what's the difference between these two patients? Does anybody know? Darn it, I was hoping somebody would help me out. Okay, we'll move on to the next. No, I'm kidding. Patient 1 is alive. Patient 2 is dead. So there are certain things in radiology that will give us anatomy, but they won't give us any physiology. And that's really important with prostate cancer. So even though the MRI says there's brain tissue up there, and there is, the PET says it's not working. So, and this kind of philosophy, this information is utilized with imaging in the prostate as well. Anatomy is great, but we need our physiology to learn more about the patient. Now, CT, very important. You've all had CT scans. It is now a legal requirement in the United States that you must have at least one CT in your life. So everybody has had many, overused, but very valuable. And I'm kidding, it isn't a legal requirement in the U.S., just California. CT is utilized for the assessment of lymph nodes, visceral disease, meaning the abdominal area and the organs, and bones. It's actually very good for bones. So it's good for everything but the prostate. It's of limited value for screening for bony metastases, but it's a wonderful tool for correlation. If you see a little something on a bone scan that you're not sure about, you do a CT of that patient, and with close to 100% accuracy, you can tell if that's a metastasis or an old fracture or trauma or arthritis or infection or whatever you think of that can affect a bone. What we refer to even now as conventional imaging. What do we start with when we evaluate our patient? And there's two things: the CT scan for the rest of the body and the bone scan for the bones. And I'm going to guess that the majority of you went through those at your initial diagnosis of the prostate cancer. But that paradigm is changing, and it's changing for a very good reason. And it's because the newer agents that we have actually can replace the combination of a bone scan and a CT with higher accuracy. Now, the CT is marvelous. I mean, it tells us things that we could not find with anything else, again, including the bone. This is an 850-year-old mummy that was found in a coffin in a garage in El Cajon. And when they found this, they said, let's see if we can figure out something about this person. What do we have at our disposal? And the unanimous answer came back, let's do a CT. Let's see what we can find out about the bones and about the patient. Now, you're going to learn a couple things from this. First of all, this patient was all huddled up in the casket. That's why she was in kind of that kind of a position. And why do I say she? Well, I say she because if you take a special view down, come here. Okay, if you take a special view down in the pelvis, see these little things here? She was pregnant. That's the rib cage of a fetus. So we knew she was 850 years old. We knew it was a she. We also knew she was pregnant. And then along the way, we could figure out other things about the bone. So CT is a marvelous entity. There's lots of good stories that go along with them. But now you've heard about the gal from El Cajon. This was probably 15, 20 years ago they found this mummy. With CT, we have extensive experience. It's got a very high accuracy for finding metastases. It might not find metastases that just put a hole in the bone. They usually have to cause that bone to start reacting and get angry and try to repair itself. But if it's just a little hole in the bone, we might not do so well in finding it, especially with CT. The specificity is poor. It doesn't really tell us all by itself what we might be looking at. And it's not really that good for monitoring response to therapy, and we're talking about the bone scintigraphy. And the reason for that is the bone scan can stay positive for life. And it's because all we're looking at is that bone that's been damaged by the cancer or anything else is continually repairing itself, and that's what causes a positive finding on the bone scan. And when I was in private practice, I had a gentleman who had fractured his arm 75 years earlier, but because it was a very, very complicated fracture, it was called an open fracture, where it actually went through the skin, needed surgeries, got infected. That thing would stay positive forever. And I saw him 75 years later for a bone scan for prostate cancer, and his left arm lit up like a Christmas tree, but it was all due to a fracture 75 years ago. There is something we call a flare phenomenon, and that's good news, is that sometimes if you get a bone scan after you've been in therapy for a short period of time, the actual bone scan can look worse. And it looks worse, but it isn't. It's actually better. What happens is as your treatments begin to work, they cause some local inflammation at the sites of the metastases, and then they get brighter. They look worse. But the bottom line is they're really not. It's just what we call a flare phenomenon. And any good nuclear physician should know that and not make the patient nervous that he's got a progression of disease when in all likelihood that next scan is going to be much better because he had a flare phenomenon. It happens to gals with breast cancer as well. Now here's a negative bone scan that came for a PET CT, which shows us a focus of uptake that was not seen on the bone scan. Okay, here it is in the cross section of the pelvis. This looks like it's in a pelvic bone. Bone scan was completely negative. If you look at the CT component, you can see that there's a focus of uptake in the middle of that ilium, the left ilium in the pelvis, that's clear, that's called lytic, and lytic lesions don't show up very well for us on a bone scan, but it was there on the CT. And then that's the PET CT where we put the PET scan together with the CT scan, and you can see the nice yellow color right in the middle of that bone, which is a metastasis, not seen on the bone scan. It was in the middle of a bone. We don't see it well with bone scans. Now, here are the other modalities that we'll cover where you're doing a good job. Very few of you are nodding off. I'm doing my best not to. So, there was one agent that was around for a while. Some of you may have had what we call a prostascent study. That has not survived the test of time. That's no longer available. One nice thing about the prostascent scan is that it wasn't too expensive. It was only about $9,000 for a study that's no longer with us. We have PET CT, which we can do with fluorodeoxyglucose. FDG is what we use for 90% of our tumors. We can do PET CT with carbon-11 choline. You know that story. It was first in the Mayo Clinic, then it was in Arizona. Very hard to find, so we don't spend any time on it. There's fluciclovine, which is Axumin, which turned out to be very, very good. It came on the scene in 2013. Was able to find things much sooner than anything else. Thousands upon thousands of those studies have been done, and it is still around and still a good study. The only thing that fluciclovine is lacking, it's not really good outside the bone. Okay, it will show us things due to the CT component, but its primary use is in bone-only disease. Then we have our PET CT studies where there's a PET scan and a CT and you hook them together and you get your anatomy and your physiology and you got agents that'll find it when the PSAs are less than 1, and that's all the rage now. So what do we have for that? We have the first one that came out of UCLA and UCSF, and that is gallium-labeled PSMA, prostate-specific membrane antigen. That one's called Illuccix. We've got the fluorine-labeled agent, which we use in San Diego, not exclusively, but almost exclusively, and it has the most play in the country, and that's called piflufolastat, or Pylarify, or PYL. Wonderful agent, lets us find things very, very nicely. There may be this much advantage to the gallium with PSAs between 0.2 and 0.4. You might find it a little sooner with the gallium. Not often enough to justify its routine use, in my opinion, but in that one area, it might be slightly better. We've got the newest one on the block. The newest kit on the block is Posluma. Has anybody heard of Posluma? Good. We are actually doing them at UCSD, not because we're advertising to do them. It's because the doctors always get approached by the marketers, and a few doctors out in the community have been successfully marketed to assume that Posluma is better than what we currently have. May or may not be. Their selling point is it might be a little better in the bladder area where we have less things to get in our way. But that's the newest one. If your doctor says you need a Posluma study, it is here, it is approved, we do them, they can be done. No real difference between that and Pylarify or PYL. And then we can use PET with an MR machine. There aren't any in San Diego. We will have one very soon for you that I'm helping getting put in the San Diego area. It's a wonderful modality to have, not only for cancer, but in little kids and in certain types of neurologic diseases. Because the beauty of the MRI is that there's no radiation. You get the best look you're going to get at the brain. You get good look at cancer. The problem is, obviously, it's an expensive venture. And we'll probably be servicing all of San Diego. But PET-MR is going to be in the future of some of you, and that's good news because it's a very valuable test. So on its way, stay tuned. Now, the tracers we use, we mentioned them quickly. Axumin or fluciclovine is good for bone. The PSMA are good for everything, whether it's bone, soft tissue, lymph nodes, organs. We find it with PSMA agents such as gallium or Pylarify and Posluma. Now, the beauty of the newest ones, okay, stick with me on this one. When Axumin was first released back in 2013, that's the top one there, that's the fluorine-based fluciclovine, they got approval to only do patients who had biochemical recurrence. That meant they had to have been treated either with radiation or prostatectomy, and then they had to have a number of other treatments, and their PSA had to go up. Straightforward enough, but not what we really needed. So when these came along, we had advanced to the point, knew enough to that point, that these agents were even more valuable in the pre-therapy setting of high-risk patients. So you did not have to have had your prostate removed. You did not need to have had radiation therapy. You did not need to be on androgen deprivation hormone, oral oncolytics, immune therapy, whatever it was. You didn't need to be on those. They have been approved in that space. So now the urologist, at the drop of the hat, are coming up with every reason why you're considered high risk. Now, we screen those, but if you are considered high risk, they want to know before they recommend treatment what they should be treating you with. And it makes sense. I mean, what's the point in staying with local radiation to the prostate if you already have a disease in your right shoulder or your left arm or the liver or the lung or wherever it might be? So now we can get that information to you with these scans. So they've become unbelievably popular. Okay, we do hundreds a month at UCSD. Oh, yeah, sure.
Is there a lowest level of PSA that they become undetected?
Yeah, and that's a real good question, and that is, I'm going to take it back in time before we had these agents, and typically in order for a bone scan to be positive, you needed to have a PSA of 10, and most people thought 20. So you needed a pretty good PSA when we didn't have these, okay? Now that we have these, if you have a PSA greater than 1, our likelihood of finding it is somewhere above, somewhere north of 90%. If you have a PSA between 0.5 and 1, our likelihood of finding it is still around 70%. If you have a PSA less than 0.5, we're down at the 30% to 40% range. But some people say, I want to try it anyway. I got nothing to lose. And if you can find it that soon, you are clearly still in the cure bucket, right? You find one spot in the right pelvis, we'll send you off to the radiation oncologist who'll fry it, and the statistics show that you have a good chance of being cured. So an excellent question, it's almost like a planted question for me, is that the reason we like these is because we can find them at very low PSA levels. Did I confuse you enough? Well, I can keep going. I can, I can make sure you walk out of here with your head spinning. I don't think we need to go through those. So let me just show you some pictures now of these things, what the scans of yours look like. First of all, fluciclovine is an amino acid. That's what it is. It's an amino acid, and it's labeled with radioactive fluorine, okay, F18. What happens with cancer, prostate cancer is what we're talking about, is there's an increase on the membrane of the cell of the receptors for this particular agent, for fluciclovine. So it's going to take it up in preference to the other cells because there's more receptors there. And the agent we use is fluorine 18, and that comes from a cyclotron. You need a great big cyclotron to make it, but we have it in San Diego. And so we just have the people at the cyclotron bleed it off and get some F18. Then they've got what they call a hot cell over here. It's like cooking. And then you put that into the hot cell that makes the axumin, and then we make the axumin radioactive. Then they send it to us, we inject it to you, and we take our pictures. Now, positivity is probably related to things like your initial PSA, the PSA doubling time, if you're not familiar with the PSA doubling time. And first, let me ask, am I going too long because we're coming up on 11? Okay. If what the PSA doubling time is if you take a PSA at time point 1 and you take it at time point 2 and you take it at time point 3, you can measure with the program that I use the one out of Memorial Sloan Kettering in New York, where if you plug those 2 numbers or 3 numbers into the program, it will tell you how long it takes your PSA to double in days. It gets very specific. And the magic number is 9 months. If your PSA doubling time is greater than 9 months, that's a good sign. Okay, you've got a very slow-growing prostate cancer. We got time. We got a tumor that's not acting aggressively. If it's less than 9 months, we have a tumor that's pretty aggressive. So we got to jump on that. And Dr. Rich Lamb may talk about it a little bit because that helps guide their decisions, the PSA doubling time. So the use of fluciclovine depends on the PSA, the doubling time, and your PSA at the time of study. For disease that's outside the prostate gland, and we're talking now about axumin, probably true with the others, disease not in the prostate, but outside the prostate, the specificity is 95%. So if I see something in your right lung with one of these agents, I'm going to tell your doctor that you have a metastasis with already 95% accuracy, because other things outside of primary tumors don't tend to take it up. So that's very helpful for us. And these are some examples. I'm going to wait just a half a minute till most of you stop seizing. I don't know why that happened there. Okay, so there's the skull. And you see this thing right here, that yellow mark? Is that a metastasis in the brain? No. Unfortunately, most of these tumor agents that we use in prostate are not terribly specific. There are other tumors that can take up these agents. And this is a benign meningioma of the lining of the brain. And that is one of the most common things we see. So if I see things like this in the brain, unless the CT component of the study tells me otherwise, this is a benign finding. So one of the reasons, in general, we're happy that you look at your scans, but in general, we want the primary physician to look at them first and clear it, because if you're sitting at home on a Saturday night at 8 o'clock and you had your scan Friday and you look at this on your record and you see this thing in your brain, what is the first thought you have? Exactly. Bring me the bottle. You know, I got to calm down here. But so all that glows is not cancer, and all that glows doesn't have to go. Okay, so that's the first one. Now the second one is a little more interesting, because this CT scan was done twice in a 2-year period, and they kept saying that this activity up here on the CT scan was just scar tissue. The patient had had some prior surgery. Doesn't look like anything we're calling a scar tissue. Well, the answer is wrong. When they had their fluciclovine study, we can see that exactly where they're calling that scar tissue lit up like a Christmas tree. So they biopsied and it was prostate cancer. So you got to put all this stuff together, and that's why these agents are very, very helpful. The last thing is this patient who complained of terrible low back pain, just terrible low back pain. There he is. So this is a CT on him going through the pelvis, and all this stuff here is an abnormal sacrum, because the normal bone is white, and then this is the whole sacrum, which is kind of gray. And they said, oh, this does not look good. So they went ahead and got their Axumin study, and sure enough, and interestingly enough, the only thing that lit up was the entire sacrum. And this is all cancer in the sacrum that took up the Axumin, but there was nothing else. So this could be addressed as a solitary region of metastasis. Now there's a little recurrence in the prostate gland. They can be very small, and we find them. This lymph node was 9 millimeters in size, less than a centimeter, and it lit up, and there's just a number of different angles for it where you can see how small it is. It's a little harder for me to make you say that you can see it over here on the CT component, but it's there. This is an example of uptake in what we call the seminal vesicle. It's just outside the prostate, at the top of the prostate. And this is depending on the way the patient is imaged, but that's seminal vesicle, prostate cancer involvement. This is someone who had their prostate removed, and this is their bladder where there's this here, and you say, well, maybe that's just the urine that's radioactive. That's how you excrete it, and that's urine in the bladder. Well, it's not, because urine in the bladder would layer out. This is a focus in the base of the bladder that had to be addressed with radiation therapy. Everything else was clear. This is in a bone in the symphysis pubis. Question mark, what's that stuff up there? Remember I told you that Axumin is an amino acid, and that's the pancreas. And the pancreas lights up because the pancreas is just full of amino acids, just loaded with them. So it's got all the amino acid receptors as well. So we see the pancreas when we look at this study as well. The question then, we have treatment once we find everything with the Axumin. And that treatment is radium-223. Is this patient a candidate? Remember, it has to be in bone. We can't have a ton of it in soft tissue. You can have small lymph nodes that are positive with axumin, but you can't have bodily organs. You can't have it in the liver, you can't have it in the brain, you can't have it in the lungs, because if you do, we're not going to cure you with the axumin, okay? It's not going to go there. So we first screen the patient to make sure they qualify. And from our look at the bone scan, it looked like he's probably going to qualify, but we don't know. So then we did our PET CT, and sure enough, in the lung, in the upper lobe there, you see a focus of activity, which unfortunately made him a non-candidate for the radium-223 or Xofigo therapy. Now, the last part of this talk, the last topic is the PSMA agents. They're the ones that are all the rage now. The indications are use in cancer diagnosis, to stage high, for looking for high-risk patients, and in the setting of biochemical recurrence, where we want to know where it is. So we have both indications now. First use in 2015, very good detection rates. That was to your question as to what we can find with it. In 2019, a study was done that showed that men were reported as having no metastatic disease based on conventional imaging, which you might remember was the bone scan and the CT. They came back fine. Greater than 50% of those men had metastases if you did one of these studies. So I'm not sure you want to stop with a bone scan and a CT if you want the whole picture. PSMA uptake can occur in a number of other tumors, as I mentioned. There was one study, we call it an impact study, that led to showed a significant fall in additional tests that men had to go through if they had one of these studies. And it's because it eliminated the need for CTs and bone scans and other things. So it had a financial impact locally and globally as well, in the right direction. There's a 300-patient study from Australia that was published just a couple years ago, and it showed that just doing the PSMA study was a suitable replacement for the other imaging studies, and we found almost 30% of those patients had increased disease. I'm not going to bore you with the mechanism of action. I've been a long time here with you, and I don't want to make it worse than it is. Here's what a normal study looks like on your left. You see some regular areas that pick it up and turn black, but most of the body is nice and clear and easy for us to look at. And Jack, our molecular diagnostic tests, which Dr. Lamb will go over with you, unfortunately show that you have a significant risk of becoming a pie. So. PSA imaging on your right there, you can see the right side of the prostate. You can all read that now, okay? You're semi-experts. And the only reason you're not an expert is because an expert is anybody from out of town. But you guys, I'm assuming, are mostly from in town, so you're semi-experts. And now you've learned how to read these things, and the entire right lobe of the prostate is inundated with prostate cancer. But the left side looks great. And there's a lymph node down there, okay? But that's all we want to know about that one. Here's where you see very, very tiny metastases. These are millimeter size. And when you do the big studies, you find that we still find them. You can take lymph nodes that don't show up in any other way because they're too small to be called abnormal, yet they've either got microscopic disease or tiny bits of tumor that are seen at the time they look at them under the microscope. How do they do in the bone? There's your bone scan on the left. There's your PSMA study on the right. And you need to convince you any further. It's in the bone. It's in the soft tissue. Bone scan maybe showed one or two tiny little spots. Here you can see a couple tiny little spots in the femurs down here, maybe a little something up here. But, you know, it's night and day. Which would you choose to have if there was a concern about it being in your bone? Here's the same patient within 5 days, all 3 studies. There's the bone scan. Well, I would choose to have that one because it looks pretty good, but that's only me. But that's going in. That's what you would want to have. Or you can have an MRI, and look how nice the MRI is. I mean, you see all these little white things that are in the middle of the bones? Those are metastases. So MRI, very, very good sensitivity and specificity. Or you can do the PSMA study, which gives you, unfortunately, news you weren't hoping to have. But it does make it easy for Dr. Lamb then to make his recommendations about what you should have. Now theranostics is the use of the same agent to diagnose and to treat. That's what theranostics is. And I'm going to kind of go through this. And these theranostic agents that we're using, they do have getting good press at this point in time. And we've got a number of theranostic agents that are here and are coming down the pipe. You've all heard of Pluvicto, which is what we use in prostate cancer, which is a PSMA agent for diagnosis and a PSMA agent for therapy. You've heard of yttrium-90, maybe, for the liver, which we use for liver cancer, which can be used to image the liver and to treat the liver. And we've got some others as well. Axiumin, the one that was the fluciclovine, the first one in 2013, paved the way for radium chloride, which is a radioactive material, because if we saw it on Axiumin, the radium chloride was going to work. And then we have the first one that goes back 100 years. And the first theranostic agent we used when we didn't even have that word in the dictionary was iodine, that we use for overactive thyroid and thyroid cancer, because we could take our pictures with it and we could treat with it. And we still do that today. We use a boatload of that stuff in our patients with thyroid cancer, and we see a lot of thyroid cancer. This is the gallium on the left. This is the patient that then got the lutetium for therapy. And you can see at the beginning, mets everywhere. By the time they got to the 3rd or 4th dose, there's nothing there. Okay, so that's how these agents can work. This is Polarify, using also lutetium. And I want to show you Polarify, which is the one we like. Here's the normal scan. Again, everything looks pretty clear. Here's activity that is seen in the tumor on the right side. Here's an example of tumor in a gentleman in his left T11, the 11th thoracic vertebra up top. He also had a little bit down below and some fluid in his right lung, which we assume was just inflammation, because that'll take it up. So he went off, and this was at a PSA of 0.5, and he had nothing else. He was treated, but unfortunately, within a period of just a few weeks, his PSA rose from less than 10, and remember 0.5, to over 200. So we repeated his study, and he had an incredibly aggressive tumor. It had changed nature and had become really aggressive. And this is now his body just a few weeks later. Just a small area that we're seeing here, which we're going to go past. Lastly, this is a patient that had a fairly low PSA. We couldn't find anything on his scans. But if you looked at an MRI and his PSMA scan, we first did a PSMA scan, and it looked to us like in the top of the right acetabulum, there was kind of diffuse low-level uptake. And then when we went ahead and did the MRI, you can see that lesion in the MRI, that dark lesion matched up perfectly, and this was the one spot we have. Now, the beauty of this, as I said earlier, is this keeps the patient in the cure bucket. That can be radiated, he can still be cured. and that's why we like to find these things early. Sometimes you get a lot of disease. This is the abdomen full of disease. Nothing anywhere else, but just a humongous mass of lymph nodes in the abdomen. This is a posluma study. You can't tell them from the others, but it's kind of a nice study. I mean, the posluma here shows us activity in the prostate. It shows us what it looks like if it's in lymph nodes here and here. And then also down here, you can see it in a bone. So it's going to find it in all the same areas that the PYL and the gallium find it. They're very nice studies, and it's just another arrow in our quiver. Let's try to, but we need more than pretty pictures, okay? We've got lots of pretty pictures to show you. But we now have to decide, what are we going to do with these pictures to make a difference in your care? And that's as we wrap up here. So what's the future bring? What are we working on now? What hopefully none of you will ever need to avail yourselves of these things, but they are there. And we're looking at combination therapies now, where we're using these targeted agents that I showed you, the theranostic agents, with immunotherapy or with chemotherapy or with radiation therapy. We are using certain other drugs that you've never even heard of. We're using what we call PARP inhibitors. We're using radiosensitizers like everolimus, which is an oral agent that you give to the patient prior to radiation, and that enhances the body's ability to take up the radiation. So it's just a way of jacking up the therapy with an oral agent. So we're looking at the combination therapies. We're looking at radioligand-guided probe surgery, where they can inject you with one of these radioactive materials, take you to the operating room, search around with the probe, and specifically find out where some of these things are, and then direct your therapy. And that's not being used in a lot of places because it takes a lot of expertise, but it can be done.
Doctor, are these all research or?
No, these are being done in certain centers around the country. Yeah, absolutely. And then there are new targets. One of the newest and most exciting is called FAPI, which is fibroblast activation protein inhibitor, and it's for all cancers. And it's had its best luck so far in, among others, prostate. And it's just another way of finding something that may even be more accurate than what we're using, if that's possible. So you're going to be reading about FAPI, and those will be available in the not-too-distant future. The other thing we're going to have soon that practically nobody else has, because we're just entering into an agreement now, is dosimetry, where we can actually measure how much of this radioactivity you're going to get and how much your normal tissues are going to get, because armed with this knowledge, we now realize that some of us are being undertreated and some of us are being overtreated, primarily undertreated. So with dosimetry, we can arrive at the personalized, safest dose to maximize the amount we give you and to minimize the amount of collateral damage. So there's a very, very fancy software that does this. We're about to get it at UCSD. So we'll have that available to any of your doctors who would like to have that information. Now, this is for cocktail conversation. Remember I told you that iodine was the very, very first theranostic agent in 1944, and it treats hyperthyroidism and thyroid cancer. Now, who in this picture had hyperthyroidism? Anybody know? The dog? I'm going to give you half credit, but I want to know, what was the dog's name? See? Yeah. No, Barbara wasn't the dog. No. So Barbara had it, but not the dog. Okay. Wrong. President Bush had it. Barbara Bush had it. And Millie the dog had it. So if you're out at a cocktail party, you guys are talking about what's going on in the world, and you could say, you know, did you realize of the Bush family who had high pressure? You just throw it in. I mean, they don't care. They're probably bored anyway. Okay. Okay, let me see. I think we might be done for now. Oh, actinium is what we call an alpha emitter. It's being worked on. It does work. We'll have that fairly soon. Yet another treatment that for after those, we can use that. Now, it's time for questions. If there's time, I'll give you answers. Or we can have you come up here, whatever Gene thinks is best, because I went over by about 15 minutes. All right.
Yeah, I can run around with the
Before I go,
microphone.
though, I want to just wish you all well and thank you for allowing me to be here again. I'll leave you with a real quick story. Anybody? It's springtime. Is anybody a baseball fan? Yeah, a fair number of you. So it's a cute story about the guy walking along the beach that stubs his toe on something in the sand, and he reaches down, and it's an Aladdin's lamp. So he picks it up. You probably may have heard about this, but don't stop me. I like the way I tell it. So he picks it up and he rubs it, and the genie appears and says, "Wow, this is your lucky day. You are allowed one wish, and I will grant that." So the guy reaches into his back pocket and pulls out a map that he opens up, and he points to the Middle East, and he says to the genie, "I'd like you to make peace here in the Middle East. I'd like to see peace in the world. And we've been striving for that for a long time." And Genie stops and he says, "Actually, I don't think I can do that." He says, I hate to tell you that. Let me give you another wish. Well, take another wish. I just can't do that. And the guy says, "Okay." He says, "Baseball season's upon us. I want you to make it so the Padres win the pennant." And the genie says, "Let me take another look at that map."
Before we go on to questions, actually, I had one for you. Just to clarify, with the impact study on doing the PSMA scan earlier on, yeah, it does seem like the question seems to have come up, like, why not do that from the start? And what you're saying is that it actually had not been approved prior to other diagnosis occurring, essentially specifically after biopsy, yes? Okay. So, and what do you think, when will that impact study change that procedure?
Yeah, and it will. And there's a double answer to that. The first thing is that is allowed to be done before anything else if the patient is high risk. So you're thinking about, what about the patient that's either low risk or intermediate risk, where the likelihood of finding it is not that high? And it turns out in the real world now, that is what's being done, is that they're ordering them more and more often. We're seeing fewer and fewer bone scans. And the physicians are just saying, "Why do I order a bone scan? Let me just look everywhere and see what I've got." So the reality is they're submitting it and saying their patient is high risk. Nobody's questioning it, and we are doing them like that.
And is there any collateral damage from the Polarify scan? I mean, this, contrast agent that they inject in you, like, is there actually risks involved with that, such that, hey, using the more conventional MRI is...
There is no risk from the radioactive studies except for the very small amount of radiation that you receive at the time of the study. And if you look at any radiation procedure, it slightly increases your risk later on in life of another malignancy. But you need a lot of radiation to get to a level where that's a statistically significant increase. So the bottom line answer is no.
Okay, thanks.
So I had a question about the DEXA, which is a slight amount of radiation. And last year, the FDA approved Echolight Reams sonogram scans. Is UCSD looking at getting that a device?
Yeah, I don't know what the rheumatology division is doing with that. My guess is they are. Probably one of the barriers to that is that the radiation from ADEXA is so minimal that they probably don't feel the urgency as they would with some other radiologic procedure. It's almost zero, okay? And I've not heard anything. I've not seen any of our patients that have had it yet, but that doesn't mean they're not getting it, because our principle we operate under is called ALARA, A-L-A-R-A, as low as reasonably achievable. We believe that no radiation is the best, that any radiation is too much. So if the data is identical, then they probably will go to it. One of the things that hinders us from moving ahead with various technologies is the expense of the technology, the very low level of reimbursement for certain studies, and the willingness on the part of the groups, physicians, hospitals, clinics out there to take on the expense of one of those pieces of equipment when they know it would take them till the 3 popes from now to gain back the money they spent on the equipment.
All right, next question here.
I'm delighted to be here. I'm scheduled for PSMA PET next week.
Oh, cool.
It's in the afternoon, though, and I won't go in the afternoon traffic up this area ever. My questions are, I was first scheduled by the MO. It said PET scan scheduling, and a little later it came out that it was. Excuse me. I'll make this as quick as I can. I said in a written thing, I said I would like to schedule a consultation so that we can discuss what type of tracer might be used and understand why this is the best choice for my care. My research has shown that there are multiple options available, as you have shown, and I've seen also in some of the forums, and I would like to better understand the plan for my care. My answer to this, it was an email, was simply, hi, Coop, this is the tracer we use for our patients' PSMA PET scans. Tracer information F18, and I can't pronounce that, but anyway, it's Polarify. A PSMA ligand. There was nothing about CT or MRI. Now, three years ago, I submitted myself to the, Dr. Arno was recruiting here, for a DOD CT comparison for DOD and UCSD. The CT comparison had with injection. The MRI was without, because they were trying to prove the MRI was more effective than the CT with. Okay. I don't know whether that could reveal by going back and finding those, but they were not very helpful in giving the patient the results. Now, getting now to where I am, I just read on a forum, or rather a study, and I'll only read the last sentence, and it involves the very things you were talking about here. It says, overall, this is the conclusion. Overall, there was not enough evidence in differentiating the 18F PC or DC, anyway, the polarity, I guess, and the GA PSMA 11, and he concludes that the decision to use either one is largely based on infrastructure available at the individual health service. And of course, Scripps sent me to the FDG because that's what they have. So I'm just wondering, I'd like to get a consultation with somebody who's an authority. Do you do consultations?
Short answer, yes, we do. Consultations, we're happy to do that for
That's
you.
it, thank you.
The second answer to your question is there is no significant difference between either agent. The third point is the reason that some people use one rather than the other, and stick with me on this, is that the fluorinate agent comes from a giant cyclotron, and the agent that's gallium doesn't use a cyclotron, it uses what we call a generator. It's a whole different production matter. So they have probably arranged to get the cyclotron-produced agent and have a contract with them rather than using the Illuccix from Telix, which comes from a generator. So it's just a matter probably of a financial arrangement they have with one or the other. But there is no difference between the two.
First, Doctor, thank you so much for your presentation today. It was really beneficial, so I appreciate this.
Thank you.
My question is, I had a visit with a UCSD doctor this week. They noticed that, and I'm going to have proton therapy at the California Proton Center. I consulted with Dr. Rossi there about having a PSMA PET scan done. And I have intermediate stage 7 prostate cancer.
Okay.
And so, and he saw no problem with this, you know. And then the doctors, though, at UCSD, when I talked with them, said, oh, you know, why are you doing a PSMA PET scan? It's like, that's really for severe metastases and that sort of cancer, and that's not who you are. Yours is all contained in the prostate, and there isn't even that much of it. So they sort of discouraged me. And the other thing they said was that PSMA PET scans generally light up a whole bunch of areas that are not cancerous. And it's just the nature of that test, that it maybe needs more development or something. But the bottom line is, I mean, they just said, well, whatever you want to do, but they weren't enthusiastic. And I just wondered if you could comment on that.
And did Carl think that moving ahead with proton beam was a reasonable approach at this point? Dr. Rossi?
Yes,
Yeah, and you say you've not had a PSMA study yet.
that's correct.
Was your Gleason score a 4+3 or a 3+4?
3+4.
Okay, well, that's low intermediate. That's a good. That's
Right.
good for you. And you know, some doctors operate under the principle that the more information they have, the better. And if our patient, and then take into account our patient's wishes, because if our patient is anxious and wants to know, and there's no harm done, except hopefully not to your pocketbook, and he feels that would be additional good information for him, there's nothing wrong with getting this study. Because secondly, we don't have a high false positive rate. It just doesn't happen with these agents. We can almost always tell if something is a metastasis or not. The last thing I would like, and I'm not trying to talk you into the scan, I'm just saying the last thing I would ever like to find out about you is that Dr. Rossi went ahead and radiated one area, and it turns out you had a second or a third one, which is obviously causing no symptoms somewhere, and it wasn't addressed, because the goal is to keep you in the cure bucket, and they do up to 5 or 6 lesions at the same time. If they find 2 or they find 3, that doesn't mean that you can't have radiation. You just would have it in more than one area. And as I said, I know I'm kind of leading in the direction of saying it's reasonable, primarily because you would like to see it done, and that Dr. Rossi would love to have a roadmap saying, look, there's nothing else you're going to be missing if we just radiate the one area or that we see, if we can see something. If it's just the prostate, that's fine. Radiate just the prostate. But if it's another area, you've missed an opportunity.
Okay, yeah, and the thing that I thought was great was that cancerous areas with a PSMA PET scan, PET-CT, will light up.
Correct.
So that you have to be blind not to see them if you're a physician, you know? So then it just gives the doctor more information. So to me, that's a plus, rather than, well, why would you want to do that, you know? So that was my only, so I kind of go back and forth. I'm leaning into doing it anyway, regardless of what they said this week at UCSD. And so,
Well, if you want to come up after we're
Yeah,
done,
thank
and you can tell me your PSA and your PSA doubling time, I can give you even a little bit better answer, but I don't want to violate any HIPAA for you. I'm not going anywhere. I have no friends.
Like the other gentleman, thanks for a great talk. Yeah,
Thank
it's
you.
really good. Doubling time. So I've got a little 6.5-year journey going on so far. You talked about a calculator for, calculating, say, doubling time for Memorial Sloan Kettering. Here I thought maybe I can go back 6 months on the PSA 6 months ago and see, compare it to what it is today and, simple extrapolation. No?
Yeah, you can. Now, realize there's been some things that have changed in between there. You've had some forms of therapy. And if it's at all possible, go back as far as you can before you were on a lot of therapy and see what it was. And any of that information is helpful. For example, if you find out that where you were, and let's just say 6 months ago, and where you are now, don't even need to know what you're on now, and that PSA doubling time is still very short, then your doctor needs to know that. You say, you were trying to get ahead of this thing, and here I'm seeing a 4-month doubling time on the treatment I'm on. Is there any reason to consider making a change?
Sure.
And you just need to go to PSA calculator. One of the first ones that comes up is Memorial Sloan Kettering, and it's the simplest thing in the world to do it on your computer. There's no training involved.
Another question. The gentleman that had the 0.5 PSA and in a couple of weeks jumped to 200.
Yes.
Can you tell us more? Because that's just like shit out scary,
Yeah, it
That
is,
can
but
happen.
fortunately, that's an uncommon situation, and it usually means that the tumor cell has changed its nature from a normal prostate cancer cell to what we call a neuroendocrine type cancer cell, and they just kind of explode. And the treatments we have for neuroendocrine prostate cancer are not nearly as effective as we have for the regular type of cancer cell. The standard adenocarcinoma that most of us have, that doesn't happen. It had to be the cell underwent a change.
Any guess on what percentage of men would have that occurring? Are we talking about like less than 1% of
No,
patients
we're
have that?
probably talking about 10% over a lifetime, and it tends to occur a little more often, or a lot more often, in men who have had a long history with lots of things done. Okay, been assaulted by a lot of different treatments. Then they have just a slightly higher risk, but it's not. It's more than 1%, and I've seen it written as high as 30%, but probably settles in around 10.
Doctor, thank you again for your time. I
Sure.
appreciate it. My question to you is, if the cancer leaves the cell, the prostate membrane, do I still need to have my prostate removed?
It depends on where it goes, and I'm not hedging at all. Picture now the prostate. It sits in an area we call the prostate bed. And around that prostate gland, there's some little lymph nodes. There is a little bit of bones around there. If the prostate cancer cells can be visualized outside the prostate, in the prostate bed, or of course they would have taken it out then, that is, you still are a candidate for local therapy because you can have the prostate removed and those lymph nodes radiated. So that does not eliminate you. Now, the flip side of the coin is that if you have evidence that beside being in the prostate bed, that's in bone, that it's in liver, lung, wherever the cells might be, the short answer is yes, you may not need to have your prostate out at that point in time, but they still need to keep an eye on you because if you respond beautifully to everything they put you on, they will come back and revisit whether it might make sense to then get rid of the prostate. So depending on where it goes, how much is it other places, it may result in them leaving the prostate in because they don't feel they can cure everything by removing it. But that also doesn't mean they can't radiate. And that's very reasonable. Okay?
And then I'm scheduled for RSI MRI next month. What is your opinion on the RSI MRI?
Yeah, I think it's going to be very helpful because you're going to get a really good look at the lymph nodes around there. And in the field of view, you're going to get a look at the bones. And prostate tends to stay local for a long time before it goes anywhere else.
Thank you, sir. And then you mentioned,
Would they?
Would proton therapy be considered in that case?
Oh, yeah. Yeah, you may have that option no matter what they do. Yeah.
thank you. And then you said the doubling calculator was at where now?
If you just go to PSA doubling time calculator, go to Google, and I think either the first or second one that comes up is the Memorial Sloan Kettering calculator. Did it come up? Yeah, and that's all you need. And like I say, there's no training involved. You just plug in a couple numbers. Okay.
Thank you again for a great presentation. My question relates to PSMA theranostics. It seems like the great preponderance of work in that area is focused on advanced, well-metastasized prostate cancers. My question is there any thinking or work or trials going on for, in the event of biochemical recurrence, when it's just getting started, when it's early, and it seems like that therapy might actually be a useful thing to do early on?
Yeah, that's one of the hottest areas in our research now is early treatment to see if that has better outcomes. So a number of centers around the country are doing just that. They're dividing their patient groups into one that goes through standard care, whatever that might be, and then those that get their theranostic agent very early in the course, and to see what happens to those two groups. The thinking is this group is going to do better, and they're going to start using it sooner. And it kind of makes sense that the lower the tumor burden, the more likely you are to succeed with getting rid of it. Because when you're looking at a lump that's this size, there aren't 152 or 619 cells there. There are billions of them, okay? So we're dealing with a lot of those little devils. And the sooner we get to them, most people feel in their gut and in their heart that we ought to get to them sooner.
Oh, Dr. Kipper, thank you for the seminar.
Sure.
Very good information. My question was, I just had a CT scan, a PET rather, CT scan yesterday. I did get some information from my urologist about the results, but I wanted to know from you, what do you think is the highest percentage rate you would get from a PET CT scan as far as the scan's results are concerned?
You mean accuracy?
Accuracy.
Pretty
yes.
high. It's pretty high. Was that done with us at UCSD?
It was not. It was done with Sharp.
Oh, okay, okay. Sometimes I can help you guys out and take a peek behind the scenes. Sorry about that. Yeah, the combination PET-CT, the accuracy is in the range of 90%. That's the percentage.
Okay.
Accuracy is based on ability to find it and ability to be specific. If you put those two things together, you come up with what we refer to as accuracy, and in a PET-CT, it should be around 90%. Okay.
Any more questions? All right, over here.
I had a PSMA gallium-68 scan done last November. So I have metastasis in the prostate bed, and he noticed a nodule in the right lung. Apparently no question about that one. But my question is, he also highlighted comment about a nodule in the left lung, but not defined, apparently, as prostate cancer explicitly. Does the PSMA PET scan also bring up other?
Yeah, the PSMA study doesn't care how many metastases you have. The number you have doesn't mean you're going to miss some due to an effect of it all going to other places. And the second thing that you have is what I would refer to as an excellent internal control. It took up in the prostate, it took up in the right lung. We know your tumor takes it up. If it didn't take up in the left lung, unless this thing is minuscule, the odds are pretty high that that's not a prostate metastasis.
Any more questions for Dr. Kipper?
Can I kick a quick one in?
Yeah.
FDG, PET/CT is okay, I'm Gleason 9, metastatic to the lymph system. Would an FDG PET/CT be sufficient?
It's a reasonable way to start, and here's why. In general, the FDG PET-CT doesn't work as well as the other agents we have. However, where FDG PET-CT works is with very aggressive or high Gleason tumors. And a lot of people will start with, if a patient has a Gleason 9, with an FDG PET-CT because concerned that it is an aggressive tumor. And then if they don't see anything with that, then they're going to probably recommend that you have one of the others. So it is reasonable. There are tumors that pick up FDG and not the others, and they just kind of fit you, and that is with a high Gleason.
All right, one more round of applause for Dr. Kipper.